Hey Refam, my name's Kate and welcome to Keeping It Real, the podcast that manages to make government bureaucracy interesting. We do, I promise. Okay, the concept of being covered by Medicare for plastic surgery is undeniably confusing. To help, we've recorded a 2-part series explaining what an item number is, why they exist, and we go through operation by operation to break down who qualifies for the surgeries we perform at RE. In this episode, we cover how both the MBS and private health insurance work, what it means to have a purely cosmetic surgery, and we go through the specific qualifiers for breast lifts, breast reductions, breast augmentations, and fat grafting. Definitely listen to this one first for a background on how the system works, and tune in next week to learn about qualifying for our other surgeries. Today, just wanted to talk about the MBS and what it is as a beast in terms of what you need to do to qualify for surgery. Anybody listening, you can always look it up on the website. Call us, we can give you the number. But all of the wording on the website is a bit jargony. So I thought that this would actually be helpful in terms of explaining what it looks like in real terms and for people instead of just a lot of silent
medical
letters.
terminology.
Yeah.
MBS online for dummies.
Yeah, exactly. So I think just to really start us off, there can be some confusion about what it actually means to qualify. And I think people can think that it's going to be free or are not really sure what qualify actually entitles them to. So can we start there?
Can we go back one step?
Yeah, sure.
And actually explain what MBS is?
Yes.
So the MBS is the Medical Benefits Scheme. There's a working group that determines what is in it, and it comprises a number of item numbers. And so if a surgery has an associated item number, then it qualifies for a Medicare benefits schedule. If it qualifies for a medical benefits schedule, then the government pays a certain amount of money to the surgeon, but it means that it also qualifies for private health insurance. And then it depends on your private health insurance cover. So there are bronze, silver and gold classifications to private health. And if you are in the right band and you have an item number that is covered in your band, then your private health insurance will contribute to the cost of your surgery, surgeon and anaesthetist, and also, but more importantly, it will cover your hospital stay, save for any annual fees that you may have to pay. It's a little bit of a misnomer calling it insurance, because insurance implies that you're betting against an event like house insurance or car insurance. Health insurance is not really like that, because you're not really betting against not getting sick or not having a surgery, because most people are going to have that. So really should be health coverage or something more accurate to what it is, because it doesn't ever cover the full cost, or very rarely will cover the full cost of actual surgery or healthcare.
And I think even the H should be hospital, because the private health insurance doesn't actually really cover much of what you're going to be having to pay. It mostly, if you qualify, covers the hospital side of things rather than our fees or the anaesthetic fees.
And just to be clear, because you see a lot of doctor bashing in the press as to why there are out-of-pocket fees. And the reason there are out-of-pocket fees is that the amounts that the government and the health insurance pay were set up in the 70s, and they haven't really increased significantly in that time. They haven't kept up with CPI or anything like that. And they haven't also kept up with technology. So the classic example is cataract surgery. So cataract surgery in the 70s was a very complicated operation. They could maybe do 1 or 2 cataract surgery. So they were long operations, and so they were very well remunerated, because generally the amount of remuneration relates to the length of the operation. And so that operation is now much quicker, and an ophthalmologist can do 15 cases in a day, but the remuneration is still relatively high. Whereas a lot of our surgery has gone the other way. Say tummy tucks or breast reductions, surgeons who trained us, and maybe even before that, maybe didn't focus on the outcome quite maybe as much as what we do. And so the operations were much quicker, whereas now we're much more focused on the end result. There's so many more steps that we do in a tummy tuck or a breast reduction that previously was just not done. And so they've become longer operations, but the MBS schedule has never been revised to reflect that. And so there are inherent problems in the system. We can't control the system.
It's so interesting. I was just reading a book and they said that her mum had died from complications, like medical complications. It was set that the loss of life from that was in the 70s was $200,000 and it just hasn't changed since then. So it was like her mum died in 2018 and it's just the same.
The value of her life's the same as it was in 1970.
So interesting. I think there can be an inherent connotation that cosmetic means like vapid or useless or like not necessary, and then people can come to us and because they don't have an item number because it is deemed cosmetic, it can invalidate them or frustrate them because that's the feeling that they're taking away that we're saying about their surgery. Did you just want to talk about that in terms of the MBS and how those definitions work?
So I think the MBS has very, very clear definitions for every single item number, and we have to play within the rules essentially. And so if you don't qualify for that strict item number, that doesn't mean that your surgery is invalid or that it's something that you can't have or that is something that's unnecessary. It just means that in the strict guidelines of the MBS schedule book, that procedure is not covered. Once you have a consult, we can explain that and lose some of the stigma that's seen around some of those procedures.
Cosmetic surgery is often maligned and referred to as more discretionary surgery, but the reality is all surgery, and this sounds a bit ridiculous, but all surgery to a certain extent is discretionary. If you've got arthritis of the knee, you don't, like as soon as you get pain, suddenly go and have a knee replacement. It gets to a certain point and then you make a lifestyle decision whether it's impacting your lifestyle. So a lot of our surgery gets confused and called discretionary and made different to other surgeries, but I think it's a lot more grey than that. I think cosmetic surgery is treated unfairly and plastic surgery is treated unfairly by and large in the MBS schedule. We're low-hanging fruit because people see cosmetic surgery as not as valuable. The reality is, I think our surgeries stack up in terms of quality of life improvement and general health improvements very well compared to a lot of other surgeries that people would deem to be more necessary or more legitimate surgeries. A really great example is knee arthroscopy, not to pick on our orthopedic colleagues who we love. So they've done studies on knee arthroscopies called sham studies where put the patient asleep, put an incision over the knee, and then in one group stitch them up. In the other group, go ahead and then do the arthroscopy for minor knee pain and the like. Those studies have shown there's no difference between those two in terms of outcome. And so it's largely an unnecessary, unproven operation, yet still an item number. And essentially what it comes down to, I think, they're a much more militant and better organised organisation than what we are as plastic surgeons. They fight these things much better than we ever have, and so they stay in. If there's an operation that's shown not to be effective, it shouldn't have an MBS code. And if a surgeon decides to still do it, patients can pay for that, be self-funded, just as our patients are for a number of operations. But that's just not the way the MBS schedule works.
Yeah, it's so interesting because it is, if you have the right spokesperson, they're like, but look at this old man, you want to take it away from him? He can barely walk. Then there's a lot more.
Yeah.
I don't know what I want. Sympathy. I was going to say pity, but that's the wrong word.
Yeah, and they don't have the word aesthetic or cosmetic. You can't go, oh, that's a cosmetic operation of your knee.
Yeah.
It's an unnecessary one. But
so we'll go through the heavy hitters of the surgeries, just overview of how they come through. I think one that a lot of people are confused about that we always get messages about, breast lift versus breast reduction. And obviously that's what your consult's for. That's what you guys talk about with the people, so they don't have to have it. But can we start with breast reduction, just because, as you alluded to, it is a lot more simple than a mastopexy or breast lift?
if you're removing breast tissue and people have symptoms which don't need to be particularly severe, then the item number 45523 applies. And currently there's no weight associated with that to qualify. In America, it's different. There is a minimum amount of breast tissue which needs to be removed for it to qualify for that item number, which has its own difficulties because you don't know the weight you're going to remove prior to the surgery, so it's hard to get pre-approval. So you could do a surgery. I'm not sure. I don't know if you know what the number is. But it's significant.
But it's also graded, so it depends on the patient's size and the size of the breast to start with. So it's not simple, and I think every health fund has a different number. So if the patient's kind of like a size 6, then maybe it's 150 grams. But if there's a size 16, then it might be like Classic 500 America. Grams. But it's like we do this operation all the time, and it's very hard to look at a patient and say, I'm going to remove 500 grams from both of your breasts. And if that came in here, it would.
And it will. Probably a lot of my breast reductions wouldn't qualify for an item number if there was a weight associated with it. But currently, in the current environment, breast reduction, if you reduce the weight of the breast and there are some shoulder, neck, back, headaches, pain, then you'll qualify. And I've never had that questioned.
And you have to reposition the nipple for that item number as part of the surgery is one of the other criteria.
But there is also one where you don't reposition them.
Correct.
So either way, you're still going to be covered. So that's pretty easy. My view, a bit pessimistic about these things, I think in our career they will introduce a weight. Hopefully not, but I'd be concerned.
Kim, did you want to walk us through what a breast lift is?
So breast lift, the criteria is for the pure breast lift item number, which if we were doing that surgery, then it implies not removing any breast tissue. So it would only be removing skin, which is reasonably uncommon. The criteria for a breast lift, you have to have photographic evidence where at least 2/3 of the breast tissue sits below the inframammary fold, which again, is pretty hard to measure. And the wording actually says on the photos that inframammary fold needs to be marked, and that the nipple is at the most dependent part of the breast. So that means that the nipple is at the very bottom. So we would have plenty of patients where their nipple is pretty low, a few millimeters from the very, very bottom part, or that they've got half of their breast tissue sitting below their fold. It is actually pretty strict, that item number. It used to be that it had to be postpartum, but that's now been removed so that you can use that item number for the significant weight loss patients.
It was even better than that. It had to be.
That's right.
It had to be at least one year from your last pregnancy and no more than 8 years. Seven or 8 years.
Yeah.
So if it got to, if for whatever reason, and so how many reasons could there possibly be? Young family, cost.
That's actually the best time to get. It's like, oh man, I've got so many kids at home. Yeah. I'm gonna get some surgery.
But the second that youngest kid turns 7, your boobs aren't saggy anymore. You don't qualify.
How is that a rule?
Yeah. Well, at least that's gone.
I hope we've got labiaplasty in this list because that's even wilder.
Yes, we need to add that. Asterisks, we're going to add that.
Is the rebate even significantly different?
No. So for breast reduction, no, same.
It's so funny that it's just like this one has, and I know you guys can't see my list, but the difference of dot points between the two, and it's like, okay, for what?
Well, I think erroneously the MBS categorises a lift as not having any functional benefit, which is just not true.
It's not true.
I think the symptoms women get from heavy breasts is equally attributed to the weight of the breast and to the droopiness of the breast. So if you've and we know this because we do breast implants all day, every day. If I put in a 400-gram breast implant, women don't suddenly get neck, shoulder and back pain that they get with heavy breasts, because when you put a breast implant in, there's generally no droopiness associated with the breast, and so the breast is still sitting all above the fold. So the symptoms come as a combination or maybe even just from the droopiness, because then the bra is having to lift the breast up above the inframammary fold. Look, the government is going to try and cut contributions to any surgery that they can wherever they can. plastic surgery is low-hanging fruit. No other doctor will get up and defend plastic surgery to get the item number in. No hospital will. Our organisations won't. So no one is going to defend it.
See, I had the breast augmentation is cosmetic, so there isn't a number.
But
I bring the experts on for this very reason, and I was put in my place. So how does obviously for the most part, breast augmentation isn't, but what about the times that it is?
So, yeah, as Kate just said, so fairly likely if you are a woman that's got small breasts that are otherwise normal but small breasts, having a breast augmentation is not going to be covered in any way with an item number. There is one asterisk to that where you don't have normal breast to start with. So either if you've got significant breast asymmetry, not like 5 grams of difference between the two sides, even 30, 50, or a developmental breast abnormality that you're putting an implant on one side and doing either reduction and a lift on the other side, or you're putting significantly different size implants, like 200 cc's different kind of thing. The other time would be removing them, and that would be even if they've got a medical complication, rupture, capsular contracture, even like malignancy around the implant, then there's item number to remove the implant. However, if you're putting an implant back in, you pretty much then disqualifies the use of that item number.
Not pretty much, it completely disqualifies.
Even if you've got a medical reason to have your implants removed.
We see a lot of people using the item number for tuberous breasts, where they're not tuberous breasts, which is Medicare fraud. They seem to get away with it, but it's not something we do. The confusing bit about this is up until about, I believe, maybe 3 or 4 years ago, maybe 5, there did used to be an item number if someone had a complication from a breast implant, like a capsular contracture or a rupture, where you could remove the implant and replace the implant, and there was an item number, and that's been removed. And I have had some patients there's one particular patient at the moment who had to have an implant replaced when that item number existed, and then had to have another implant replaced after that. And that was very confusing, and she got caught up in the whole that I was saying that it was now not necessary, whereas I'm not saying it's not necessary. I'm saying there's no item number.
Yeah.
But
the cost to her, the difference would be quite significant because of all the hospital costs and paying for the implant. And
because it helps them go PHI.
No, it would cover the implant as well. And I think that was a mistake, us not fighting that more, because my view is, so someone's paid for their breast implant, and we can go through, in the 70s, there was an MBS item number for a cosmetic breast implant, and we lost that as well. If someone has paid to have their implant in, my view is that is their then baseline. If they then have private insurance on top of that and there's a problem, then they should be entitled to having that implant then restored back to what is their normal. We don't put any penalties or restrictions on smokers or alcoholics or people who have accidents, drink driving. They're covered by TAC, or they're covered by insurance if they've got insurance. And so I've always thought it's unfair that if someone has paid to have their breast implants put in and have insurance, and then they have a problem, that they should be able to be returned back to their baseline. But again, it was low-hanging fruit. No one put up any fight to keep it. And even amongst plastic surgeons, when I've raised that, I get shouted down. I don't quite know why, but you would think they'd be on my side. But I think we give these things up a lot.
Because even just like contract law, basically, it's like, okay, but I've paid for this product and this service to continue, and it's been interrupted.
And going back to calling it insurance, like you'd think that's what you could pay for insurance for.
What about fat grafting? Does that have an item number?
For most of the procedures that we do, there isn't one.
It legitimised using it. So for a long time overseas, people were fat grafting breasts. There's a famous guy in America who were doing a lot of fat grafting into breasts, and that I think it was the TGA wouldn't allow us to inject fat in breasts because it was considered a risky operation. But then an item number was introduced for breast reconstruction, but what it did was it opened it up to make it not forbidden for injecting into a normal breast. And it's an incredibly useful adjunct to all breast surgery, whether it's implants or lifts and reductions for shaping or just adding more volume. As I always like to say, it's the icing, not the cake. I find it incredibly useful, but up until maybe 10 years ago, we weren't even allowed to do it.
Yeah, I think there was a time where you had to apply to the TGA if you wanted to do that. And I think part of that as well was the radiologists were a bit like super nervous for a while about then doing mammography. The fat that was going to be injected was going to disguise any malignancy or any abnormality. And then that was clearly proven overseas and in many different studies. So I think that all then just petered out a little bit. And I think it was because we had to maybe even notify our insurers or have a specific thing on our insurance if we were going to be injecting fat into a breast.
Yeah.
And then that kind of petered out quite a bit before then this new item number came in, and there was campaigning to get it approved for breast reconstruction and also for some types of burn scars. And that's what they're probably two of the newer item numbers that have been brought in the last couple of years.
Yeah, so if anyone who works at the Medicare benefit schedule is watching this podcast, and we hope they are, it's not all bad. We found one benefit from all the hard work that they do.
And lower body lift got a bit better.
Lower body lift got a little bit better.
But if anyone wants to chat to us about our opinions further,
we're open.
All
right, thanks, guys. If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.